Lucy can't be with us today, so we are going to go straight into our first presentation, looking at DBS, which is deep brain stimulation, and really all the questions I think that you've ever wanted to ask about deep brain stimulation. And I'm going to welcome Dr. Ledingham onto the stage, as it were, onto the virtual stage. Hi, Dr. Ledingham. And Dr. Ledingham is based, as I am actually, in the UK, based up in Newcastle. And Dr. Ledingham is consultant neurologist and clinical lead for movement disorders at the University Hospital in Newcastle. So welcome, Dr. Ledingham.
Thank you. Morning. I will just try and share my slides then. Just 1 second. Okay.
Yep.
Can I check if you can see my slide though?
Yeah, perfect.
Yeah. Okay. 1 second. Okay, perfect. Morning. Nice to meet you all. Yes, like you said, I'm Dr. Ledingham, one of the neurologists from Newcastle in the UK, and I work at the Newcastle hospitals and also a senior lecturer at the Newcastle University. I've got 20 minutes to talk about deep brain stimulation for dystonia, so if I do it justice, and hopefully there'll be 5 minutes at the end just to answer any questions. So what I thought I'd outline it as is 5 different aspects. So what is deep brain stimulation? I think probably one of the more important questions is what is the procedure actually involved? And then going through who's it for, how effective is it, and maybe a little bit about future directions. Although I know there's a further research talk later, so I'll try not to overlap. So first question, what is deep brain stimulation? So in a nutshell, deep brain stimulation is the process by which we apply high frequency electrical stimulation to some of the very deep structures in the brain. And so you can see from this diagram, if you take the middle diagram on the right, that in, for example, dystonia, what we're trying to do is apply high frequency stimulation to an area called the globus pallidus interna, very deep inside the brain. We know that there are a number of different conditions, most of them movement disorders, where there is some of their symptoms or a number of their symptoms, individual symptoms can be due to an abnormal connection or abnormal signals between a network of different structures deep in the brain, particularly structures like the basal ganglia. And we know that stimulating and interfering with those abnormal signals can significantly improve symptoms. So deep brain stimulation is now an established treatment for many movement disorders. And there's also some experimental work or used in some countries, applications for conditions such as OCD, epilepsy, and depression. Worldwide, I understand the estimates are about 200,000 people have now deep brain stimulation in situ. So deep brain stimulation is how we apply electrical frequencies, electrical stimulation, electrical current to these deep structures in the brain to affect conditions like dystonia. Deep brain stimulation has been around for a while, actually. So the modern era of deep brain stimulation is considered to have been around for about 30 years, but people had considered it even before then. Really, it came about relatively opportunistically. So we know there's a normal network which is contributing to some of these symptoms. And what we really found very, very early, or other people found very, very early, is that lesions to those networks would often improve those symptoms. So an opportunistic stroke, for example, would improve the symptoms. And that led people to explore early on whether or not we could do that as a therapy. So some of the early surgeons would create holes in those same structures and improve symptoms. And over time, we wondered if we could do it without damaging the structures, but instead by applying stimulation to the structures. And that's where deep brain stimulation came from. So you can see from as far back as the 1990s, people were applying stimulation to the globus pallidus interna for dystonia and noticing an improvement. And then it was in 2010, 2014, where the larger trials showed that there was a clear improvement versus placebo in conditions like dystonia. But it's really evolved over time. The technology's got better, the electrodes got better, and how effective it's got is also better. So probably one of the more important questions, what does the procedure, what does deep brain stimulation actually involve for an individual? And I have to say first that there can be a lot of variation between different centres. So even in our own unit, different consultants will do it slightly differently. And I know that there is some variation across the UK and across Europe. The key point is probably the same. So for all individuals going through the procedure, what will happen is that you need to apply 2 electrodes to those deep structures in the brain. So people will, you will have an area of hair shaved, have the electrodes placed through a burr hole in the brain for the deep structures, and those electrodes will then be connected via wire to a battery-like device in the chest, and that provides a stimulation. What might differ is whether individuals do it awake or asleep. So in our centre, actually, we rely more on the imaging beforehand to guide where we put the electrodes. So all patients are under a general anaesthetic and asleep. But elsewhere in the UK, elsewhere in Europe, people might be awake. Some units feel that if you place the electrodes in, turn the stimulation on, that means you can see what benefit side effects you might be able to get in theatre and make sure your electrode's definitely in the right place. So there is some variation in that. So if people are awake, you can see that they see from this picture that they're placed in a device that fixes their head in place and allows the surgeon then to be very precise about where to place the electrode. And this you can see, so it's called a stereotactic frame, and this really allows the degree of precision you need to target these very small structures in the brain, the globus pallidus and terna. So it allows for exactly the right angle, and the pre-operative imaging allows you to work out exactly the depth you'd want to put the electrode into. So what happens in the procedure, and again, this might differ slightly between different units, but in our unit, we'd put both electrodes in, the wires in, and the battery in all at the same time. Different units might do that as a step procedure. This is what essentially you would end up with after the procedure. And you would end up with some small scars just on the head, which often be hidden by the hair, in the chest where you put the pacemaker, and a little bit behind the ear where you tunnel the wires. So the wires are all under the skin. This is what you would be left with afterwards, after everything's healed. You can just about make out the wire hidden behind the left side of the neck there. I think it's just at the right angle to show it. Often you can't see it, and you can just about see the outline of the battery or the pacemaker device. I have to say it's like one of the older devices because it's bigger than you'd expect to see now. And he's a very slim gentleman, so it's more obvious. But in people who carry a bit more weight, you may not be able to see it. You can see that we've got a number of different devices, a number of different companies manufacturing the devices, and the batteries have evolved over time. So where before we may be putting in batteries that last for 4 to 5 years without recharging, now there are much smaller ones like this one, which you can recharge every couple of weeks just by placing another battery over that pacemaker and recharging for an hour. The devices, so the rechargeable ones are actually, they can last for up to 15 years now, and they are often MRI compatible as well. People can go for an MRI with it in. What you probably do want to know is kind of what would be the risks of surgery. So when I speak to my colleagues, the neurosurgeons, they consider this quite a safer procedure than most, because for them it's a very small procedure, a burr hole and putting the electrodes in. It's not removing a large lesion, for example. But there are still some risks, and it depends a little bit on the unit, a little bit on the clinician's experience. If you look at the literature, similar to what our site would suggest, probably about 1 or 2% of people, 2 or 3% of people may have a bleed or a small stroke during the procedure. Chance of that being significant, actually, it's low, it's 0.7%. The other risk that we would often emphasize that sometimes the risk of having infection, either of the electrode, the wire, or of the pacemaker. And sometimes that can mean antibiotics, sometimes it can mean having to replace the wire. Rarely, we can put the lead in the slightly wrong place. By misplacement, we normally mean literally just by a couple of millimeters, and that can sometimes make a difference to programming. And rarely people can have a seizure or even be a bit confused after the procedure. What I would say, and what I would do emphasize to people who are kind of going through deep brain stimulation surgery or considering it, is that probably this procedure is only one part of the story. When we have the device sited, the next important part is to try and program it and to make sure that we're stimulating the right structures in the right place to get the best benefit and the least side effects. And this is a really nice diagram because it really does show kind of what we're aiming at. So these small structures, so this is the structure we would stimulate it for dystonia. That's an area called the globus pallidus and terna, is what we aim for. And in fact, we aim for a very small part of the globus pallidus and terna, this part that's deepest, most of the outside. But you can see that there are lots of structures very close by. So you can see this blue structure underneath, that's something called the optic tract. So that carries information from the eye to the brain. And this sort of curtain or blanket structure that comes down the top of it, something called the internal capsule. And that controls how we control movement on the other side of the body. So if you stimulate the optic tract, sometimes you can get flashing lights. And so if you stimulate this blanket structure, the internal capsule, sometimes you can get pulling on the opposite side of the body. Anything we do with stimulation at that point is reversible. You just turn the stimulation off. But what we're trying to do in a programming session is to get the best response and the least side effects. And how we do that has changed a bit now. So practically what we would do, at least in our unit, is bring people back about a month after the procedure, and then we'd have a much longer session with them, so up to 2 hours, where we would test the different contacts. So I'll just try and show you that. So yeah, so if this is pretend this is an electrode, you can see here that along this electrode, there are 4 different contacts, which I'll just show you. So bottom contact, and then coming up, there are 3 more contacts. So what we would do in clinic is that we would stimulate that bottom contact and see if that gave any symptom control, any side effects, and then work our way up to see what the side effect threshold was before then moving to the next contact, then the next contact, the next contact, see which one is most appropriate. We have got things to help us. So actually some of the newer devices, we can see the anatomy all outlined with the electrode in place, so we can often target the structure we think we should be targeting. But we usually do a brief screen just to make sure there's not a more appropriate target clinically. Ultimately, you get stimulation in this area, and that's what we're aiming for. You can see this one's a smaller diagram, but you can see we're actually aiming for a very small part of this globus impellor, this part just here at the back. So you can see how accurate the surgeons have to be. And you can see how the electrodes have changed over time. So from what we were discussing, you have 4 contacts. Some of the newer electrodes actually have segmented contacts, where we can actually try and steer the current in one direction coming off from the lead, which can further improve our outcomes and reduce side effects. I can just show you on the next slide how that might work. So for example, if you're looking down the electrode, you want to target a structure on one side, but you want to avoid this side. By using this segment, you can really throw the current across this way, and you can shift the area you're stimulating by several millimeters, and that can have a significant improvement, a significant impact on how good your outcomes are and how your side effects are. I think the other important thing to know from deep brain stimulation and programming, and something that we really try to emphasize before someone goes through a procedure, is the time frame where you might see a response. So dystonia is a little bit unusual, actually. The conditions like Parkinson's and tremor, often just turning on the device will lead to a significant improvement in symptoms, which you can see in clinic and you can use to guide therapy. And dystonia is a little bit different. So we broadly divide the dystonia symptoms into what we call phasic symptoms, this purple group, and what we call tonic symptoms. So phasic symptoms means these are the fast movements we sometimes see in dystonia. So the fast jerking movements of the neck or the tremulous movements of the neck. Whilst tonic movements, we mean by that more the fixed postures that turn towards one side, the torticollis. What you can see is that whilst we might see some early improvement in some of the phasic, the fast movements, the jerky movements, the tonic movements actually take a lot longer. So this is probably underestimating it, to be honest, but the tonic movements sometimes can take weeks, months to see an improvement. So what we're doing in clinic when we increase stimulation is that we are more guided by side effect profile than often by clinical response. What has to happen over several sessions is we have to bring you back, slightly increase the stimulation each time until we get the best outcome. As you can imagine, sometimes we might have to move contacts or reframe the beam of stimulation, and that can mean there's quite a lengthy process. So we normally suggest to people that probably the best outcomes you'll get from the device are going to be 6 to 12 months down the line, just because of how slow the improvement is. There's an important factor to take into account when you're considering the surgery. I think the next most important thing is who might be suitable for deep brain stimulation and who might not be. Certainly in the UK, we take into account a number of different factors, and I suspect this is very similar for most of Europe. We have commissioning criteria, so set by the NHS, about who we should be stimulating. We need to take into account what other treatment options might be available for an individual. And we need to take into account aspects related to their dystonia or aspects related to their other health issues. And we'll talk a bit more about that individually. So this is our guidance set up in 2013 that basically commissions how we use deep brain stimulation for movement disorders in the UK. I boiled it down to 6 points, and I suspect this is very similar to how clinicians would approach it in most countries. So key is we need to have an established diagnosis of dystonia. So we need to make sure that it's not a mimic. Most commonly a condition called functional dystonia, which is different and unfortunately doesn't improve with deep brain stimulation. We also need to make sure that an individual is suitable for surgery. So I mentioned that we do ours on a general anesthetic, so they have to be suitable for a general anesthetic. So if an individual has significant cardiovascular or respiratory problems, that might preclude them from surgery due to safety issues. The commissioning criteria also state that dystonia has to be severe enough to compromise significantly the quality of life of an individual, and that's probably a given. They need to be severe enough to warrant surgery. The other important point down on the bottom left here is that dystonia has to be the primary cause of disability. So we'll talk about this a bit more, but some people have isolated dystonia, I'm sure you know, where it just affects where the only problem is dystonia and there's no underlying cause for it. Other individuals may have other symptoms alongside their dystonia or other areas of the brain affected. And these areas obviously can't improve with deep brain stimulation, and hence people won't have as good an improvement with deep brain stimulation, and we need to take that into account when suggesting surgery. And the other aspect is if an individual's had dystonia for a period of time, you can get some underlying bony changes. So, for example, if people have a foot dystonia, you can get arthritis of the ankle, which means that even if you improve the dystonia, you're obviously still going to be left with a degree of joint deformity, and that might people may not get a significant benefit from that, given that. The other aspect, people need to have been refractory to other medical treatments. That normally means that they've tried the medications, so trexafenadil, clonazepam, for example, and they've tried botulinum toxin injections. But that's an individual to an individual's dystonia. The patient-related factors that we look for, so we talked a bit about it. So is the patient suitable for the procedure in terms of their other medical conditions? And we also need to know whether or not there are any structural challenges to surgery. By that I mean, is there a blood vessel that's too close to the structure we want to stimulate and make it unsafe for the procedure, for example? And what we mentioned before, are they able to cope with the procedure? If it's an awake procedure, are they able to understand and cope with the degree of follow-up that's needed afterwards? So the expectations of surgery. This is a slightly complicated summary, but it summarizes what aspects of an individual's dystonia might make them a better or worse outcome. It might better or worse outcome from DBS. We talked a little bit about how if dystonia occurs on its own, people are probably a better candidate than if it occurs with other neurological conditions or other underlying causes, such as due to cerebral palsy or due to a stroke. We also know that some body areas may improve better than others. So we know that the most common areas affected, things like the arms, the legs, the trunk, the neck, may improve better than the bulbar areas. By that I mean swallowing muscles, speech muscles. We know that an individual's had dystonia for longer may not improve quite as well as someone's had it for a shorter period of time. And as we mentioned before, so the slower movements, the postures, the turns of the neck, they improve slower, and they may not also improve to the degree as the faster movements. What's also interesting, some of the dystonia genes, genetics, we currently recognise a small proportion of the genes that are responsible for dystonia, but some of them might predict a better outcome than others. So I guess that's individual to individual dystonia. I think this is quite useful to highlight. I'll just go back to highlight that certain body areas may improve differentially to others. So the areas that we commonly use, common indications for surgery, so the neck, the arms, and maybe the trunk, seem to respond quite well. So on average, about 60% for cervical dystonia, whilst the areas that we don't commonly stimulate, which we don't, not common indications for surgery, like the swallowing muscles, they don't tend to do quite as well. So on average, more like 30–40% improvement with deep brain stimulation. I think the other thing this diagram highlights is that there's quite a lot of variation in how people improve. So you can see that whilst most people with cervical dystonia will get about a 60% improvement, some people will get a very good improvement and others will get a relatively poor improvement. And we can't entirely predict for an individual how well it will work for that individual. And we need to counsel people about that before the procedure. So practically, what do we do? So in our unit, it'll be reviewed by an individual who is considered candidate for deep brain stimulation will be reviewed by a neurologist or neurosurgeon first. They'll undergo an MRI of their head. they'll have a neuropsychological evaluation to see if they're a suitable candidate, and if they understand and have the correct expectations from surgery. And then after getting some severity and quality of life assessments, we'll discuss them together in a multidisciplinary team meeting. So the neurosurgeons, the specialist nurses, neurologists, and neuropsychologists in our unit will discuss whether an individual is a good candidate, is whether they'd like to benefit from the surgery. So the next question is, how effective is deep brain stimulation for dystonia? What we would say in our unit, and probably comes out from the literature, is that for conditions like generalized, idiopathic, or isolated dystonia, that's dystonia affecting multiple areas of the body, we would predict that on average, people will get a 50 to 60% improvement in their motor scores, so the degree of dystonia at about 1 year. And that's quite similar for dystonia affecting the neck. What we've noticed from the literature is that probably can continue to improve even after that, up to about 1 to 3 years afterwards. So yeah, and it's usually that the effects of the deep brain stimulation sustained long term. Like I said before, that there is a bit of variability in how well people improve. Some people can get a very dramatic improvement, and others get very little improvement. We do counsel people in our service that maybe about 20% of people will get very minimal improvement. And by that we mean less than 25% improvement in motor scores. So a little bit, very briefly, about future directions from deep brain stimulation. I think this is quite a nice diagram. So it highlights here on the left what's the current status. So currently we've got a electrode implanted via the wire into the battery in the chest. Currently we haven't rechargeable batteries, and we have electrodes placed into a structure on both sides, so symmetrical placement. In the future, what many companies are working on right now, several companies are working on right now, are some significant changes to that. So there are some companies whereby rather than having the battery implanted in the chest, they actually have the battery implanted in the skull. So a much smaller system, which may be a faster procedure and obviously may have less cosmetic changes for an individual. The batteries are changing, so they are now lasting longer and longer on each charge. I think some of the newer companies are saying 2 to 3 months in between charging, where at the moment a lot of them are people who are recharging at weekly intervals. There's also the question about whether or not we could be targeting different areas of the brain and getting better responses, or even multiple areas of the brain and getting better responses. That's all being looked at right now. I think one of the other interesting aspects is whether or not we can have a more physiological deep brain stimulation or an adaptive deep brain stimulation system, so-called closed loop. This is probably one of the areas I find quite very interesting, and we're trying to look at a bit more here in Newcastle, and I suspect several centres around the world are looking at as well. But we're looking at, rather than delivering a continuous current, the very same current to that area of the brain 24/7, 7 days a week, which is what we do now, whether or not we should be modulating the degree of stimulation over time. We all know in dystonia that the symptoms can vary, can fluctuate, and you wonder whether if people have had a more severe dystonia at that time point, should they deal with more stimulation? Should they have more stimulation? And if their dystonia is well controlled, should they have less stimulation? But currently, there's no capacity to do that. What is happening in the Parkinson's world at the moment is that there are some new devices commercially available which can both stimulate but can also detect intrinsic brain rhythms, something called local field potentials. So this is the diagram here. So in Parkinson's, you stimulate a different structure called the subthalamic nucleus, and you can see just on the right on the top, what they've begun to detect is that there's a rhythm called the beta rhythm, which correlates really nicely with individual symptoms. But it correlates really nicely with how stiff or slow an individual is with Parkinson's. And so the higher the beta rhythm, the more slow an individual is, the stiffer they are, the more tremor they have. And what they're starting to do, and what there are some randomized controlled trials looking at now, and hopefully should come out later in the year, are having AI-developed algorithms which will increase the stimulation when the beta amplitude is up and then reduce it when it's down, thereby hopefully improving symptom control and also minimizing side effects. You don't have to be at such high stimulation amplitudes all the way through. And we're hoping that that might well provide a more physiological deep brain stimulation and lead to better outcomes over time. It's still early days. For dystonia, There actually is some early data that suggests that low frequency rhythms, such as something called theta rhythms, may have a similar correlate with the symptoms of dystonia. So early days, but whether or not we can also develop an adaptive system which can modulate the degree of stimulation depending on individual symptoms and hopefully provide better control going forward and faster control going forward. So yeah, so that's basically the end of my talk. So thanks for letting me speak again. Any questions from anyone?
Hi, Dr. Ledingham. Honestly, there are tons and tons of questions. So, what I'm going to do is field them. I think we're going to focus on, I guess, more patient-related ones first, and then if we've got time, move on to the scientific ones. So, first question really is, success rate. Is there a difference when this is carried out, this procedure, when the patient is awake or when they are anesthetized?
I don't think my understanding, there's quite a lot of debate about this. My understanding is that there's not a significant difference between the two. In our unit, certainly we feel that the preoperative imaging that we do is good enough to help us target that same area compared to when people are awake. But I suspect other clinicians might slightly disagree. I don't think there've been any clear head-to-head studies, and there's still quite a lot of debate at many of the conferences we go to about which is better. So I don't have a very clear, I don't have a 100% clear answer on that one, but I believe the imaging is as good as the people being awake at the moment.
Okay. And kind of related to that, how do you know that the electrode's in the right place, both when they are anesthetized and when they are awake afterwards?
What I might do is just show you. So what they will do before, and they'll do beforehand is they'll have an MRI of the head, and then they'll either have an MRI or CT intraoperatively, and they will be able to reconstruct using the current software the different structures of the brain. They'll be able to work out the exact angle, so they can simulate it and plan it on imaging software, and be able to work out the exact angle to place an electrode based on that software, and then they use this stereotactic frame to get exactly the right angle for the electrode position and to work out exactly the right depth. So that's what people have put into the frame when they're in surgery. So it's a mixture of pre-planning and using the frame. That and then not, so that's how you would do it with imaging. The other ways of doing it are, as we said, if you're awake, sometimes you can turn on the electrode in theatre and you can see whether or not an individual gets a clinical response. And there are other ways whereby um, you put the device in and you can record different signals from the structures. And so the different signals might give back different structures might give back different signals. That could be another way of making sure you're in the right place. There are a few different strategies that different centers use.
Okay, thank you. Um, Another question. When a patient has received this and they have the implant in place, is there anything they can't do? So, for example, flying, going through, metal detectors at airports, that kind of stuff. How does their life change afterwards?
They can do all of that. They can certainly flying. There's probably a period of a couple of months after surgery where they shouldn't fly, but after that it should be as normal. Going through magnets, airport security, it will beep, but normally we give individuals a letter just to say that you've got a device in. It is very rarely, I've not experienced with any of our patients, sometimes a battery can turn the device, a large magnet can turn the device off. I think that's rare, probably more with the older devices. But patients normally have we give all patients a patient controller as well. So you can actually turn the device on and off on your controller. So if it did turn off, you just turn it back on again at the same
Okay.
stimulation settings.
Okay. So with that, you talked about a large magnet. What about an MRI? So say they were going for that kind of scan. What kind of precautions would they take?
Okay, yeah, so it's a bit device specific. So the newer devices have all been evaluated and they've got CE mark for being used. Well, many of them have been CE mark for being used in different MRIs at different intensities. So some of the new ones are compatible with what's called a 1.5 Tesla MRI, some of the 3 Tesla MRI. What that practically means is that they are safe to go in an MRI scanner, but often you should talk to your DBS service first because there are often some settings you would change it to first to try and minimize any risk to the battery. The older devices, they may not be safe to have it with an MRI. So it's really best to check with your DBS team what your device is capable of, what the precautions should be. But
Okay.
practically, new ones can probably have an MRI, but they might need a slight adjustment in their settings before and after, and a check before and after.
Okay. And what about before they have the procedure? Can they actually have their normal treatments, for example, Botox, physio before, or is there almost like a washout period before they have the
No, I don't. There's not. They can go on as before. There shouldn't be a real change to that. The hope is that the Botox might become more and more unnecessary after the procedure, but often that continues for a period of time whilst we're trying to work out how good the deep brain stimulation will do. But
Okay.
they don't have to stop anything beforehand. No.
Okay. And then after the event, after the actual procedure, what's the downtime? What's the recovery period afterwards?
So we keep people in hospital for about a day or two if everything's gone well, and then discharge, and people will kind of gradually. It's a general anaesthetic, so they'll gradually improve over the next couple of weeks. But they'll be so certainly in our centre, they'll be at home recovering.
Okay. And we're good. We're ahead of time, so we can, if you're okay with this, we can keep firing
Yeah.
some questions over to you, if that's okay.
Yeah.
Um, So what about if you can comment about the use of AI? So I'm imagining that kind of variation in the treatment, the actual using predictive technology. Is that AI based? Is that if you can explore that a little bit more with us?
But basically it's an adaptive algorithm that will
Mm.
increase the stimulation depending on the level of the signals they're detecting, the local field potentials they're detecting. I guess technically it is artificial intelligence. It's not
Yeah.
yeah, I'm not sure it's on the greatest, most superior scale of artificial intelligence, but yeah, it increases stimulation when the beta frequency is high, for example, in a condition like Parkinson's.
Okay.
But it's clever and hopefully it should improve outcomes.
Yeah. Okay. And I've got a question here. So with the adaptive stimulator that we've just talked about, does it change the level of the stimulation in real time? I would imagine it does, doesn't it? It's instant, isn't it?
It's instant, yeah.
Yeah.
There's a very short lag of kind of seconds. Yeah.
Yeah. Somebody's just put wow at the end of that. Yeah. It's real time, isn't it? Real time adaptive stimulation. Okay. Somebody's asking here, do you have experience of using DBS for, and I may mispronounce this, Meige syndrome and blepharospasm?
I've not blepharospasm. We haven't put a deep estimation for blepharospasm locally. May syndrome, we do have a couple of patients with May syndrome. Um, the literature suggests that the response there is a little bit variable. We would still offer it if it is severe enough and other treatments have failed. But you just have to be a bit cautious on suggesting how much of a benefit will give.
Okay.
Um, yeah, there's not been as many trials on it's kind of that it's a rarer condition, I guess, and not as many trials for that specific type of dystonia.
Okay. And I have questions coming in on my phone and questions on two screens in front of me. So just bear with me if my eyes are flitting around a little bit. But do you have data, stats on the relative use of DBS across European countries? Is one country more likely to use it than the other? Or is it quite
Um,
consistent? Do
I'm
you think?
sorry, I don't know that one. I know the data for the UK. I know that does vary a little bit. But I'm sorry, I don't know the European data as such. No.
Okay, no, no problem. And I mean, if I may ask you, within the UK, are there clusters within the UK where this is carried out? And would patients be able to travel? Say they lived in, oh, I don't know, a really country area in Cornwall, would they be able to travel to different centres of excellence to receive the treatment? Or is it more kind of postcode lottery?
So they I mean, so the DBS centres in the UK they're obviously focused around the major cities. There are several in London, and then there are a number throughout the UK. But they would all be patients should all be able to access it. I guess different clinicians might have different experience if if they're being looked after locally. But essentially, if your dystonia is not improving and there's still significant dystonia after trying several treatments, it might be worth having a discussion. They should all be and any individual should be able to refer to a local centre. So I think I don't know, Cornwall would be something. I guess it would be Bristol. Bristol might be the closest centre for that, but yeah, they should all be able to refer into a
Yeah,
centre. Most because most neurology neuroscience departments are all hooked up with the kind of the district general hospitals and sort of a hub and spoke type pattern.
yeah.
You should be able to be referred into your local neuroscience centre, and it's certainly available in all areas of the country, Scotland, Wales, etc.
Okay. Cool. And moving on to quality of life. I think you mentioned quality of life, and we're talking quality of life beforehand, but also afterwards. How is that assessed? Is it a subjective patient response, or is it a quality of life questionnaire before and
It's
after that take the
cool
measure?
questionnaires. Yeah, so we've got a number of different questionnaires that where patients will subjectively, I guess they will fill out on a scale how severe they feel the symptoms are before, compare it with afterwards. And there'll be a number of questionnaires that look at different aspects of that, and we can compare before and after.
Okay. Okay. And I have another one here that is the patient's DNA analyzed for faulty genes before surgery?
Um, I suspect different centres will differ depending on whether they've got academic interest in that. We don't tend to do a patient's genetics unless there's a high chance of getting a normal result. So there's a very strong family history, or if they have maybe a young onset generalized dystonia. My
Okay.
understanding is that individuals with sort of focal forms of dystonia, so maybe just involving the neck, are developing later in life without any other symptoms, it will have a very low yield of in the genetics, so we'll have only about a 1 or 2% pickup from what we from the genes that we know at the moment. That might change over time, but at the moment there wouldn't be much point in offering those individuals genetic evaluation. You're probably more likely to get an irrelevant or a result compared to a useful result.
Okay. And I'm sorry, flipping back to the quality of life, there's one here. How do the quality of life questionnaires capture fluctuations? I think that's meaning post implant. How often, how frequently do you do the quality of life follow up?
I mean, there isn't a specific questionnaire. I'm aware of a dystonia that specifically asks about fluctuations in symptoms. They kind of just ask, how have you felt if things have gone over the last month? We tend to do one at 1 month, 2 months, 6 months. That's how we do our questionnaires. And then after that, it's kind of standard clinic. How is it? It's just on a clinical point. How's it gone over the last 6 months?
Okay, brilliant. And I feel like I've bombarded you with questions. I do apologise, but the final one is within the UK. How many centres are there? And we have kind of covered this really. They're the main hubs. How many in the UK are offering DBS? How many centres are there? But also, have you a feel for how many DBS interventions there are in the UK each year? Is it quite widespread?
Okay, I don't know the exact number of centres, but I guess just kind of going down. I know Newcastle, Sheffield, Leeds, Manchester. I know London, Bristol. There must be a few units in between. Um, I know that Glasgow covers Scotland. I'm not sure about Cardiff. In terms of how many people are doing, I, and so our unit is doing about 40 patients a year, and I think at one point I worked out that we were the sixth, the kind of fifth or sixth in terms of the size. So I don't know exactly, but maybe about 200, 300 patients here. I don't know if that's underestimated. I'm not entirely certain.
It's almost like, isn't it? It's like nearly one a week, isn't it? With the data you've given, really, excluding Christmas, it's almost, if it's 40, it's
Right, yeah,
just
yeah.
under, isn't it? One a week. Yeah, one
That's
every fortnight, maybe.
for
Yeah.
Newcastle, yeah. So presumably that
In
would be similar
Newcastle.
for, yeah.
Okay. Okay. And I do apologize. I did promise last question we can, if we can squeeze in just maybe one or two more. When the patients have received this treatment, I think you said that you alluded to that there should be a reduced need for Botox post procedure. Do they tend to have those procedures afterwards, or do you see that they are almost treatment free after the procedure?
Because as I probably suggested before, that there can be a bit of variation in how well people respond to the procedure. So it really depends on how well they've done with deep brain stimulation. I think the majority of patients will need less of the Botox, and a significant number will not need the Botox anymore. But again, because it can sometimes take a bit of time for you to get the best outcomes, I often will continue to inject people until you're certain they don't need it anymore.
Okay.
But the needs will often reduce over time.
Thank you. And I think I'm going to finish this with just a final question. I'm going to paraphrase it a little bit, which is, I mean, do patients feel concerned before this procedure, and particularly related to a question here about avoiding parentheses sensitive areas of the brain during the procedure? How do the patients feel when they're about to go through this procedure? Are they grateful? Are they glad? Or is there obviously some nervousness and anxiety about the sensitivity of it?
I think there's a lot of variation there as well. I think that there are certainly people who are can be very nervous about it, understandably so.
Mhm.
We would try and put kind of those individuals in touch with other individuals who've already had the deep brain stimulator, just so they can have a chat through, see how it's gone. And often the specialist nurses are also really useful for kind of talking people through. And I think they've got the other end of the spectrum of people who just are just so fed up with it, just only they're willing to do. They're very keen to have any procedure, and they're just very keen to get on with it. So yes, I think there's a big spectrum, but with certainly people who are more worried about it, we try and get them to have a discussion with other people who've had it already, just so they can talk through their concerns.
Perfect. Thank you so much for that presentation. I've enjoyed it because what you've done is take something that obviously is incredibly complex and made it understandable for a lay audience. So it's been brilliant. Thank you.
Right,
And I
thanks very much.
really enjoyed listening to you. Thank you so much.
Thank you very much.
Thank you. And now we're going to move on to the next speaker. We're